Hello, everyone. Thank you for joining us today from all over the world. Today, we're going to be talking about COVID-19 and hearing from two experts in public health and emergency preparedness, Dr. Scott Gottlieb and Dr. Paul Biddinger. I'm Lindsay McNair, and I'm the Chief Medical Officer for WCG. WCG is the world's leading provider of solutions that measurably improve the quality and efficiency of clinical research. Through the Word Copernicus IRB and the WCG Clinical Services Organization, WCG enables biopharmaceutical companies and institutions to accelerate the development of new therapies while maintaining the highest standards of human subject protection. Today, we're going to ask each of our expert speakers to talk to us for about 15 or 20 minutes, and then we'll move to answering your questions. You'll see on your screen a field in which you can submit questions during the broadcast, and we also have dozens of questions that were submitted to us online during the registration process. We'll try to cover as many of those questions as we can today, but we won't be able to get to all of them. Dr. Gottlieb, as you can imagine, is being pulled in a lot of different directions this week. He's not online with us yet, but we hope that he'll be able to join us in just a few minutes. But we're going to start with our first guest speaker, Dr. Paul Biddinger, and I'd like to ask our co-host for the webinar, Jeff Osborne, the CEO of Acumen, to introduce Dr. Biddinger. Jeff?
Thanks, Lindsay. As Lindsay said, I'm Jeff Osborne, the CEO of Acumen, and for those who don't know, Acumen is an industry leader in performance-based partnerships for hospitals and health systems. We have decades of experience helping hundreds of healthcare clients really accelerate their journey to performance excellence with clinical laboratories, imaging, radiology, supply chain, and various patient blood management programs. So we appreciate the opportunity to engage in today's conversation. Our first speaker is Dr. Paul Biddinger. Dr. Biddinger holds several leadership positions in the area of emergency preparedness with institutions such as Mass General Hospital, the Harvard T.H. Chan School of Public Health, the Massachusetts Medical Society, and the U.S. Department of Health and Human Services. Dr. Biddinger is an active researcher in the field of emergency preparedness, and he's lectured nationally and internationally on topics of preparedness and disaster medicine. He's also responded to a number of previous incidents, including Hurricane Katrina, the Boston Marathon bombings, Superstorm Sandy, and the 2015 Nepal earthquakes, and many others. Dr. Biddinger, thanks for joining us today. I'm going to turn it over to you, and we look forward to hearing your comments.
Thank you so much, Jeff, and thank you, Lindsay. Thanks to everyone joining today. Just before I keep going, can I confirm you can hear me well?
Yes, we can.
Great. Thank you so much. And again, thanks to everyone. Obviously, I think the temperature feels like it's rising in the press and in the country every single day, and so I'm going to do what I can to be helpful with providing you some knowledge on the situation as well as some perspective from the healthcare side. I believe that Dr. Gottlieb was going to sort of set up the stage for the virus and its epidemiology and what we know now. And obviously, we all have to adapt, which is completely understandable. So I'm going to cover a little bit of that, but try not to steal any thunder for when he presents. But the basics I think everyone is pretty familiar with. It's been widely reported in the press that this new coronavirus, a third significant coronavirus, emerged in Wuhan, China in late 2019, really started to overwhelm the healthcare system there in January and has now spread to so many countries with well more than 100,000 cases diagnosed, but probably many, many more that are undiagnosed. Now, I think we're seeing certainly significant community spread in much of the United States. We obviously are all aware of the outbreak in Washington. There are other hotspots, including New York, and even here where I am, up here in Boston, Massachusetts. And I think really what we are seeing is that it is a time where we are shifting a lot of our messaging, a lot of our response efforts, a lot of our activities from containment to mitigation. This coronavirus, in some ways, does not act like the prior two coronaviruses that we've had that we are concerned about, and those are SARS and MERS. With both SARS and MERS, it was not possible to transmit symptoms before you had infection, and you only transmitted infection before you had symptoms, and it was only possible to transmit the virus when you had symptoms, and that made both viruses relatively amenable to public health controls. SARS, of course, was controlled relatively soon after it appeared on the global stage and has not been seen since. MERS still occurs in small numbers, but there are not large numbers of outbreaks because, again, we can typically control cases of SARS by identifying social contacts and using appropriate isolation and quarantine. With COVID-19, that's not the case. The disease is clearly spread by both asymptomatic individuals as well as by individuals before they begin to feel ill, which is a characteristic of influenza. And that makes it much more difficult, I would argue impossible to control with public health measures directly. Once the disease is in the community, especially because of the minimally symptomatic or the asymptomatic spread, but also because transmission can happen before patients have symptoms, it really takes root. We have seen across the world that there are some communities that have been tremendously hard hit, and some not so much, and it doesn't always correlate with their public health infrastructure. The outbreak in Taiwan has been really mild and relatively contained as compared with China. And there are other countries in the world with much less developed public health systems who still have had relatively smaller outbreaks, while other larger countries with more developed public health systems have had much more significant progression of disease. I think where we are here in the United States right now is in a pretty well acknowledged state where we have increasing community transmission. So we have to focus on how to mitigate the impacts of this outbreak, and really how to try and make sure that we can deliver the best care that we can for everyone infected. And so I was talking to others just before we started this webinar to say that I think a lot of folks now have seen these social distancing curves with and without protective measures and social distancing for what the impact of COVID-19 could be on the community. I don't think it's possible to put the genie back in the bottle. I think we're going to continue to see rising numbers of cases, but I think a lot of our efforts, maybe almost all of our efforts, are focused at blunting that epidemic curve, keeping the peak as low as possible, because that peak is where the medical demands, the need for care potentially exceeds capacity. So the higher that peak is, the more people that we may see who need hospitalization, who need intensive care, who need resources like a ventilator or ECMO, which is a version of bypass to help support oxygenation. The higher the peak is, the more we can't provide those kinds of resources. So we are trying so hard for social distancing. I think these events have clearly been gaining steam in the last couple of days across the country. Not too much longer than a week. It's hard to believe that only a week ago, most of this would have been unfathomable, with sports leagues canceling seasons, with the degree of social distancing we're seeing, the degree of of school closures, et cetera. But again, it's all about trying to save lives. It's all about trying to shift into this this mitigation strategy to blunt that peak, so that the outbreak may last somewhat longer, but that there will be fewer cases at the peak and fewer unmet healthcare needs. So, the impacts broadly, I'll just name them. I don't think these are going to be a surprise to anyone on the phone, but, we're anticipating large surges in patients, both in the ambulatory and in the inpatient care settings. This means primary care doctors, urgent care doctors, emergency departments already are fielding huge numbers of phone calls about concerns, and seeing increases in patients who may be presenting with respiratory viral illness. So fever, cough, sore throat has been a prominent symptom, others. And then on the inpatient side, both to the floor, normal medical units and the intensive care unit is very much of concern. We'll talk about that in a minute. Supply chain challenges have been huge. I think personal protective equipment is probably the greatest challenge on the medical care side. Access to N95 respirators, the most high filtering respirators for healthcare workers, went in short supply almost immediately in the country in January, long before there was any clinical need, and still we haven't quite figured out how that happened, that manufacturers and distributors try and do a good job of allocating to hospitals and not letting anyone buy up the market, as happened back in 2009 with H1N1, but still went in short supply. And now really every aspect of medical personal protective equipment, including gowns, gloves, eye protection, are difficult to obtain on the market. As we see increased surge in the ambulatory and inpatient arena, there's going to be significant displacement of clinical services and really also of research efforts. And this is for a combination of reasons. We want to promote social distancing even in the healthcare setting, just fewer opportunities for people to come next to one another to transmit disease from one another. Trying to protect especially vulnerable patients, so patients with immunosuppression, older patients. If there are ways in which we can defer visits, that's going to be extremely important, as well as, frankly, decrease our consumption of resources. So fewer opportunities to need to use personal protective equipment is going to help protect the response overall. We are seeing already decreases in the available workforce. So either nurses, physicians, others who have an exposure to a patient who is being suspected of COVID and therefore is furloughed for 14 days, or healthcare workers who become ill themselves. And we're doing everything we can to protect the healthcare workforce. That is extremely important, that we have a workforce that can come to work and does come to work. But some degree of illness is inevitable because, frankly, they're in community spread. It will be spread at grocery stores and other public venues, and some degree of transmission is unfortunately not preventable. And in the setting of this, there's a lot of healthcare worker fear, just like there's a lot of public anxiety. There's frankly a lot of fatigue. My own hospital and my own healthcare system have had an incident command system activated since late January. Now I'm running sort of 6 weeks plus into emergency response mode, where we're meeting every single day, 15, 16-hour days. Everybody really flat out, and that obviously takes a toll at every single level, including in all of our frontline staff. So I want to go through sort of each one of those a little bit individually, but I'll try and be brief, talking about testing, talking about ambulatory care, emergency department, inpatient care from the healthcare perspective, and then obviously be happy to field questions. We can talk a little bit specifically about some research questions in addition. The problems with testing in the United States have been extremely well documented and unbelievably frustrating for everyone involved in this response. I think it's really extraordinary to look and see how different the U.S. ability for testing is as compared to really almost anywhere else in the world. There are 23 tests per million people in the United States, and that's the lowest of any industrialized country that we know of. And compare that 23 tests per million to 2,800 in just Guangdong, China, or 3,600 tests per million people in South Korea. And really, when you look at that testing capability or testing per capita, it's really hard to say that we have a good handle on how much disease there is in the U.S. We just don't know because we can't test. And really, although absolutely we need more testing in every way. We have to know who's infected, who's not. We have to know where disease is. There's an especially urgent need for testing in the inpatient side of hospital care and for healthcare workers. If I don't know if you have the disease and you have compatible symptoms, I have to treat you as though you have the disease until I know otherwise. That means we use more and more personal protective equipment. It means we use more and more of our isolation capacity in the hospital, whether that's, again, on the floor or up in the ICU. And we put more people at risk by trying to potentially even have to cohort individuals together. If we can't test quickly as we make decisions to admit people to the hospital, as we identify what gear we're going to wear, we are going to consume a huge amount of resource that we shouldn't need to consume, and we're going to run out of isolation spaces. So rapid testing available to the clinicians in that ED and inpatient setting is extremely important. And then on top of it, there's been a lot of talk about whether we should have testing broadly available to anyone who wants it. I would say two things. We do want as much testing as possible for all the epidemiologic, all the disease transmission reasons that are obvious, but we really do not want a centralized ED-based, emergency department-based strategy or urgent care-based strategy for testing, because we actually saw in China, we saw in South Korea, those healthcare systems being overwhelmed by patients with mild illness coming in for testing, mixing with those that don't have illness, and frankly overwhelming the healthcare system. So our testing strategies for broad-based public testing have to be much more thoughtful. Obviously, people have seen something with drive-through clinics and others which don't bring the well and the ill together and don't overwhelm the care systems. Those are the things we really need to look at. On the ambulatory care side, important to talk about how challenging COVID is in the ambulatory environment. Even with the earlier CDC recommendations, which did just change this week, initially testing and patient evaluation was supposed to be done in an airborne isolation infection room, a negative pressure room with the medical staff wearing an N95 respirator, gown, gloves, eye protection, and those things really aren't available in an ambulatory care setting. There was a provision that patient evaluation could be done in a closed-door room if an airborne infection isolation room wasn't available, a negative pressure room wasn't available. But even in most primary care doctors' offices, the availability and the training for gowns, gloves, N95 respirators, eye protection is actually really quite low, because that degree of protection is really not needed in the ambulatory space. I mentioned already that in the ambulatory space, social distancing is something we're already thinking about. So people have been trying to defer visits of older patients. Probably, again, all of you are aware that the mortality increases substantially with increasing age. Really, there is an inflection point at about age 50, and the slope of the curve continues to increase with each decade of life after that. So 60, 70, 80, it's not a linear relationship. It actually is something of an accelerating relationship between age and mortality. So we want patients not to have to come in if they don't have to. So we're deferring visits, but we're also doing lots of other things, such as telemedicine. Lots and lots of rollout of telemedicine, virtual visits, so that providers can see their patients, but can do it in a way that protects both and decreases both traffic, public transit, lots of demands that we would like to avoid. And then some people, of course, do absolutely have to be seen in person. So rather than have patients with acute respiratory illness spread out across a large network of primary care offices, a lot of systems are trying to develop concentrated or specialized respiratory testing clinics, respiratory evaluation clinics, so that patients who do need a clinical evaluation can go to a focused area where the ingress and egress can be focused, the personal protective equipment is concentrated, the training of staff is optimized. So again, both from a healthcare worker and from a patient perspective, these risks are minimized. We have such a clinic within my healthcare organization, and we've even taped the chairs to the ground 6 feet apart, so we enforce some of the best practices for social distancing. Some of these clinics really have to be located near emergency departments. A lot of the public will go to an emergency department as their primary source of care when they're concerned. Some folks don't have illness that is so significant to need an emergency department evaluation. So finding ways to preserve the ability of an emergency department to care for patients with heart attacks or sepsis or trauma or other needs is really important, and so that co-location is essential. In an emergency department setting, we're starting to see, depending on where you are in the country, rising numbers of patient presentations and some degree of rising numbers of significant illness. EDs, emergency departments, are already crowded and are really not great settings for infection control in the first place when they're crowded. As soon as the crowding worsens, then the opportunity for disease transmission increases. So again, trying to make sure they have access to the right PPE as well as isolation spaces. We do still need these negative pressure rooms when we're doing what's called an aerosolizing procedure. So if you're intubating or giving a nebulizer or suctioning a patient, those patients do have to be in airborne infection isolation rooms, the negative pressure rooms. Those are in incredibly short supply in any emergency department, in any hospital, and trying to provide rapid turnover to meet the demand of patients coming in is starting to be a challenge for some hospitals. On the inpatient side, the CDC did change their criteria for the recommended isolation environment. Initially, everyone was recommended to be placed in an airborne isolation room. Now, it's just those patients that have aerosolizing procedures, so that's helped a little bit. But first off, there's just a problem with supply. It's not a secret to anyone that hospitals have to operate at pretty close to full occupancy in order to stay economically viable. That means that our surge capacity is quite limited in terms of the beds available, as well as the nurse and physician staff who are available. So we're really concerned about that supply and demand mismatch, and that's unfortunately exactly what we're seeing play out in Italy, and worse yet, in Italy, we're seeing, and others, they're not the only ones, but it's the worst there that I've seen documented, the lack of resource availability. So specifically ventilators, ECMO devices, things that are life-saving, potentially are exceeded. And I led off with some comments about flattening the curve of the outbreak. Part of the reason we flatten that curve is that there's so many models out there, and it's obviously incredibly important to remember that a model is not a prediction. A model is simply a way in which we try and anticipate demand. But it was pretty widely reported in a couple national publications in the last couple of days that peak demand potentially could be on the order of 900,000, 1 million ventilators across the outbreak, not all at the same time, but across the outbreak. But the most optimistic assessment of the United States healthcare system is that we have about 100,000 ventilators, so a 9 or 10-fold excess of demand over capacity. So really, the more we can flatten that curve, the more we can do to make sure we have life-saving resources. As we look ahead to these kinds of severe supply and demand mismatches, we are increasingly looking at how we share information across healthcare systems. Competitive healthcare systems don't do a great job of identifying where they have capacity and where not. We have to coordinate that well. And then especially if we do end up in a circumstance where that supply-demand mismatch is so substantial, we have to start moving down the path of something called crisis standards of care. This is something that the Institute of Medicine, now the National Academies, have been working on for more than a decade. Lots of people have been thinking about, but it's very hard to implement. We need to have protocols and policies that are fair, they are transparent, they are evidence-based, they are consistent, and they're shared across healthcare organizations so that one hospital in one system does not do something vastly different than another hospital in another healthcare system, which undermines the confidence of the public in our ability to respond. So I'll just close with a couple of words about research in the healthcare setting as it relates to the hospital and the healthcare response. I think this is another area of challenge, like just about everything with COVID-19. I think there are both bench research or basic research questions as well as clinical research questions that we are absolutely struggling with right now. On the bench side, many academic healthcare systems, including my own, have tried to see what they can mobilize from the research community in order to better assist the response. This includes equipment, this includes technicians, this includes reagents, and this is really because, again, there's just such an extraordinary need. Right now, many hospitals, again, my own Mass General, Brigham Women's within my system, are developing their own tests. Mass General is going to roll out its own test today. However, it is a heavily manual process that we have to extract the RNA, we have to run it on a special instrument and use reasonably sophisticated technicians in order to get the result, which is vastly different than what we do in almost all of our other microbiologic testing. So we across Harvard have been pulling together, have made an emergency call for RNA extraction kits, repurposing certain instruments, and potentially looking at creating a volunteer corps of trained microbiologists, others who are comfortable with RT-PCR and this kind of lab work to be redeployed to assist us with our bandwidth. On the more clinical research side, I think there have been some very unfortunate challenges. Really, it's hard for us to be able to continue to support clinical encounters with patients where either the research assistant or the researcher may come in contact with COVID, and just from a risk management standpoint, as well as, frankly, a resource utilization standpoint. We cannot use a single piece of personal protective equipment that could be used otherwise to protect a healthcare worker and a patient in the course of clinical care. We have made massive changes to how we're using students, to how many people enter a room for every different clinical encounter. We actually have rolled out iPads on poles that we put into COVID patients' rooms so that the nurse and physician team have to enter that room fewer times, therefore consume fewer gowns, gloves, masks, etc. So this is having definitely an impact on our clinical research capabilities. At the same time, there's an incredible need for knowledge. With an unprecedented outbreak like this, we certainly have to understand what is going on. We have to continue to acquire knowledge. We don't want to also, frankly, just put the entire scientific enterprise on hold for a year and stop the advancement of medical knowledge. So we're having some very hard discussions about how to continue selected research studies and when we need to stop other research studies. And again, it's that balance of safety, resource utilization, and importance of the project. So I think I'll stop there. That's an awful lot for 20 odd minutes, and probably most of it pretty depressing, so I apologize. But I did want to try and share what I can to be helpful, and certainly eager to answer questions from the audience after Dr. Gottlieb.
Great. Thank you very much, Dr. Biddinger. I think that was great. It was very helpful to us. And thank you in particular for addressing those questions about clinical research. We do have a lot of our audience that is from the clinical research community, and as you said, a lot of questions about those topics that were submitted to us. I do just want to let those people who are on the call who are interested in the impact on clinical research know that WCG is also having a webinar on March 18th talking about the impact of COVID on clinical research studies. If you would like to join that, go to WCGclinical.com and the events page, and you can register for that webinar there. We may be able to address more specifically some of the detailed questions in that forum. And I don't think we have Dr. Gottlieb on the phone with us yet. So Jeff, would you like to start with the first question for Dr. Biddinger?
Sure, and as you can imagine, Dr. Biddinger, there was a lot of questions. We pulled a few that we thought we'd ask you. One of the ones that came up was the last possible infectious disease outbreak that we prepared for on a large scale was Ebola in 2014, and fortunately that stayed contained to a small number of locations. Did the hospitals and institutions learn any lessons from that experience that really are providing benefit today as we prepare to respond to COVID-19?
Yes, I think so, and it's good to be able to share some good news with all of the challenges. I think, many hospitals and healthcare systems felt unprepared in 2014-15 for the challenge of Ebola, and as serious a disease as Ebola is, really in a nation with a significantly developed healthcare system, public health system, it's much less of a threat. It's a disease that's only spread with symptoms. It's only spread by contact. So we are grateful that disease outbreak didn't spread further. But what did happen is that the United States government stood up something called NETEC, the National Ebola Training and Education Center, which is housed among the University of Nebraska, Emory University, and Bellevue, to conduct research not just on Ebola, but any other emerging special pathogens. And then NETEC has been supplemented by a network of regional Ebola and other special pathogens treatment centers. These acronyms are a little cumbersome, but RESPTCs. And that means that across the country, there are 10 of these RESPTCs. My hospital, Mass General, is the host of one. I'm the head of that program. And what we've been doing is preparing for something like this coronavirus outbreak. So for the last 5 years, we've been planning, developing protocols for how you hospitalize someone who needs this kind of isolation. We've developed donning and doffing protocols, specialized our PPE protocols. We've developed training videos, planning tools, others. We actually, in late January, as this was advancing, we were able to leverage a lot of that work from our program into a toolkit. It's still published on my hospital disaster medicine's website, and it's been sent out nationally and internationally. It's been translated into Chinese, Italian, etc. So that's just one example of building on the shoulders of previous experience. The other thing that I would say specific to Ebola is, although again, COVID and Ebola are very, very different diseases in so many ways, but the importance of donning and doffing personal protective equipment, taking off your PPE carefully, is one of our most important lessons learned. I think, unfortunately, we're still seeing a little bit of this out of China and South Korea now, that the doffing process, how you take off your PPE, is maybe one of the most important things that any healthcare organization can focus on. Sometimes there's been discussion between the big full body suits that are in the news, especially in parts of Asia, and contrast that with some of the gowns and gloves that are used in healthcare PPE here. The aerosolization that can happen, the mobilization of particles if you shake your PPE incorrectly, if you take off your PPE in the wrong sequence, so you take off your suit, you have already taken off your respiratory protection, a bunch of small droplets get kicked up in the air and you breathe them in. That's very, very real. And so we have very tight sequences from Ebola for how you take off your PPE. We have developed the same for COVID, but we're trying to get the word out to everyone who's actually donning and doffing PPE how important being methodical and being careful in the doffing is going to be for personal protection.
Excellent. Very, very helpful. Do you have a view, Dr. Biddinger, on if and when the coronavirus hits large hospitals, should they create clean and dirty teams and kind of put those in place to minimize cross-infections? And kind of what lessons have we learned from triage of care when the care needs exceed the capacity that's available in the hospital?
Yeah, so I would say, and I'm not sure if this is what the person.
Hi, it's Scott joining. Sorry.
Oh, welcome. I'll finish off this answer, and it's great to have you join. I'll certainly be happy to hand it over. I think the idea of a clean and dirty team, and again, this may not be what the person meant, but is something I guess I would not recommend because it sort of inherently implies you don't trust your personal protective equipment, that there's a dirty team. And so maybe what the person may have meant instead, which is something I strongly endorse, is the idea of specialized teams in specialized areas. As I said previously, the putting on and taking off of your PPE, even if it's not the full body suit, which is again not what we're wearing. We're wearing a gown, gloves, either N95 respirator or face covering, but that doffing process is actually something to get right. You want to have people who've practiced it who are really good at it. Frankly, also, you want to be able to concentrate your supplies of PPE in a certain area. You also would love to have areas that have good infection control procedures like chairs 6 feet away, et cetera, good air handling. And so clean and dirty spaces or specialized spaces, maybe that's a better way of saying it, is the specialized space is incredibly important. So we on the ambulatory side have special clinics where we've really trained up our nurses, physicians, advanced practice providers for that evaluation. Same in the ED, same on the inpatient setting. And then when patients are admitted, they're admitted typically to cohorted areas where they're not sharing the same airspace. Each person is in an individual room as per CDC guidelines, but the team in that area is really focused on the care of that kind of a patient. So I think that's really important, but a clean and dirty team a little bit less so.
Thank you, Dr. Biddinger. And Dr. Gottlieb, thank you for joining us. I know you're being pulled in many directions today, so I'll just give you a quick introduction and then turn the floor over to you. So Dr. Scott Gottlieb served as the 23rd Commissioner of the U.S. Food and Drug Administration. He now serves on the board of Pfizer and Illumina, and he's a resident fellow at the American Enterprise Institute and a partner at the venture capital firm New Enterprise Associates. Prior to being the FDA Commissioner, Dr. Gottlieb served as FDA's Deputy Commissioner for Medical and Scientific Affairs, and before that as a Senior Advisor to the Administrator of the Centers for Medicare and Medicaid Services, where he helped advance policies to improve healthcare quality and promote the effective use of new medical technologies. Dr. Gottlieb is widely published in leading medical journals and periodicals and has held editorial positions at British Medical Journal and the Journal of the American Medical Association. So Dr. Gottlieb, I'll turn the floor over to you for your comments for 15 or 20 minutes, and then we'll take a few more questions if we can. Thank you.
Great, thanks a lot, and I appreciate the opportunity to join the group today. Obviously, we're in a difficult period right now. We're really at the sort of beginning of what is likely to be epidemic spread of the novel coronavirus here in the United States. If you think about the situation in South Korea and Italy as proxies, about 90% of all the cases that were diagnosed in both of those countries have been diagnosed probably in the last 10 to 12 days. And you look back about 2.5 weeks ago, Italy had 9 cases. And so this moves very quickly. And I think that we're going to find, as we get very broad diagnostic screening in place next week, we're going to start to turn over the card on a lot of additional cases. There was an announcement today of an approval of a high throughput platform by Roche that's going to be able to substantially increase screening. And so as that gets into place, as labs start to implement testing on that platform, which can literally enable tens of thousands of patients to be tested on a daily basis, I think we're going to turn up a lot of new cases. And if you look at the testing that's been going on in the country, there's been a very high positivity rate. And so partly that's a reflection, I think, of the fact that appropriate patients are being tested, and there's sort of a pool of patients who were presumed to be infected with coronavirus based on clinical criteria, and in fact are. But partly it's also a reflection that this probably has been spreading for some time. The other challenge with the United States relative to other countries is that we're a very mobile population, and we've probably seeded the infection in multiple parts of the country. And so I think what you're likely to see is multiple outbreaks grow up simultaneously in disparate regions. To give you sort of a proxy, if you look at Seattle, where there's probably a very large outbreak underway, the modeling showed that there could be upwards of 5,000 cases just from a single cluster that had been identified as of this coming Sunday. Seattle Airport has about 44 million domestic passengers coming through that airport annually. Those are passengers flying through Seattle to other parts of the United States. By comparison, the airport in the Hubei province in China has about 24 million international and domestic passengers coming through the airport, so far less transit through a much bigger region of China. So you just didn't have the same mobility in China that you have in the United States. So that's likely to complicate the circumstance here. And the question I think some of us are grappling with is, will we look like Italy or will we look like South Korea? South Korea looks like their epidemic has peaked. They've had a declining number of cases now for almost a week. And they've had about upwards of 8,000 cases and I think about 65 deaths, versus Italy, which has probably upwards of 15,000 cases now and over 1,000 deaths. In countries that are relatively similarly sized, I think the population of Italy is a little over 60 million. The population of South Korea is about 51 million. So countries are about comparable in size. South Korea has obviously had a much different experience. And so what did they do right? They put in place strict, really aggressive mitigation steps early on to engage in social distancing, trying to get people apart to break off chains of transmission. They also implemented very broad-based diagnostic screening, and so they were able to identify their clusters very early and identify people who were infected within those clusters and get them into quarantine. They had an epidemic. They were certainly past the point of containment, but they were able to use some of the tools of containment to reduce the scope of the epidemic. Versus Italy, which was very slow to implement the mitigation steps, allowed the virus to spread in the country. And now they're at the point where their healthcare system has been virtually overwhelmed, and they have an epidemic that is, on the brink of being out of control in the country. The purpose of mitigation steps and social distancing, as many people on the call know better than I do, is to you're not going to necessarily reduce the number of people who get infected over a period of time, although you can. But what you try to do is keep the peak of the epidemic below the point at which the healthcare system gets exhausted. And what happened in the Hubei province and what's happening now in Italy is the surge in cases came so fast that the healthcare system became exhausted and above the point at which the healthcare system was no longer able to adequately care for patients. You had a dramatic rise in deaths versus South Korea, where they were able to put in place mitigation steps, closing schools, having workers telework, canceling large events. So that slowed transmission to the point where their healthcare system was able to adequately deal with the people who were presenting who were infected. When you put in place those mitigation steps, you can actually extend the length of the epidemic. So the epidemic could be longer. If you think of an epidemic curve as a mountain with a very sharp peak, that's a normal epidemic. If you do nothing, you get a very sharp rise in cases. And then after a sufficient portion of the population is infected, you start to see a drop-off in infections, in part because the people who are susceptible and were going to be infected have become infected. And in part, once you get a sufficient number of people infected in the population, it creates a natural wall of immunity. It's hard for new infections to form. The goal of mitigation is to basically take that peak and push down on it, flatten it out a little bit. and extend it out. And so the total time of the epidemic can actually get longer, but the number of cases at the peak is a smaller number of cases. And that's what you try to do with the mitigation steps. I think right now a lot of the concern, the diagnostic issues, I think are going to be resolved. Some of the things that they're doing now, perhaps we should have done 6 or 8 weeks ago, getting the large clinical labs like LabCorp and Quest in the game, getting the academic labs in the game, but we are where we are. Those things are happening now. The high throughput systems are being approved. I think you're going to have substantial screening capacity next week online. I think the second thing that needs to happen is that we need to get a more consistent approach to how we implement the social distancing and the mitigation steps. Right now you see an ad hoc approach among states and localities and even among businesses, where some states are being very aggressive. I think New York is leaning forward very aggressively. And then some states, I think, haven't been as aggressive. Seattle and Washington State have been slow to implement some of these steps. So we really need a more systematic approach, and we need to lean forward and be far more aggressive right now on these things. The third thing I think that needs to happen is we need to take steps to try to reduce burden on the healthcare system. And so this gets into things like, should hospitals be putting off elective procedures? I would counsel that they do, thinking about trying to reduce volumes in the hospital. What can the government be doing to try to alleviate burdens on hospitals? Should any hospital be undergoing a JCO audit this month? So there's probably things administratively that the government, both state and federal government, could do to try to, reduce some of the burdens on the hospitals and put things off that isn't going to adversely affect patient care in the near term, while the hospitals are focused on a much more difficult challenge right now. And I think that those things need to happen. I think on some level they are happening right now, but again, not in a more systematic fashion. And so I think that you're going to hear hopefully more discussion about that in the coming days, trying to take a more systematic approach to these things. So just sort of in closing, how dangerous is this virus? I think that all the emerging evidence is that this is a dangerous virus. This may be a sort of once-in-a-generation pathogen that straddles that really, terrifying area between being contagious enough that it can spread pretty efficiently, but still virulent enough that it could cause a lot of death and disease. So when you look at the data, the case fatality rate looks like it's going to be about 1%, maybe a little bit less. And the transmissibility of it, what we call the R naught, the ability of people to get infected, so how many new infections do you get for every one infection, that looks like it may be between 2 and 3. And we certainly heard anecdotes where, in a single setting, one person has been able to infect a lot of individuals. If those statistics hold, this is a very frightening pathogen. And while there's a lot of discussion about how it's mostly affecting older Americans and you can try to protect people who are most vulnerable to it, that's certainly true. I mean, it's tragic that it's affecting older Americans in such a disproportionate way. And it's certainly true that we could take steps to try to mitigate the impact by asking people who are vulnerable to it, people who are over the age of 60 or have pre-existing health conditions, to effectively stay home for a month and really not try to engage in any social contact. There's still a lot of people in between the other age groups, 30, 40, 50, getting very sick from this virus, and you still see deaths. To give you sort of some crude numbers, the case fatality rate in some of the analyses that have been done for people between the ages of 40 and 50, I paid particular attention to that group being 47, is about 0.2 to 0.4. So that means 1 in 250 or up to 1 in 500 people who get this between the ages of 40 and 50 are going to die of this. That's an enormous figure for a virus of this kind. It is dramatically higher than the case fatality rate for flu within that age band, which is more like 0.02 or even less. And so this is a dangerous pathogen. Once you get into the older age ranges, you look at 60 to 70, the case fatality rate is about 4%, 70 to 80, it's as high as 10%, and when you get above the age of 80, it's as high as 14%, depending on what data you're looking at. Those are the high end. That's the data that came out of China. It would likely be lower here in the United States, especially if we can adequately address our healthcare needs in the setting of an epidemic, but still exorbitantly high. And the other thing I would just say, and I'll sort of close here, is the other thing we looked at is hospitalization rates by age. And when you overlay hospitalization rates by age of people who are hospitalized in China with coronavirus outside of the Hubei province, so I didn't look at data in the Hubei province because their healthcare system had become overwhelmed and the data got skewed by that. But when you look at hospitalization rates outside of the Hubei province and other provinces where they didn't have the big surge in cases, and you overlay that with hospitalization rates for seasonal flu in the United States, and you look at it by age, you see something very striking. Now, all the usual caveats, the threshold for hospitalization in the United States is much different than China. Threshold for hospitalization of young people is much different. Threshold for hospitalization in the setting of an emerging pathogen like this is going to be different. So certainly not apples to apples comparisons, but the data was striking in that in parts of China outside the Hubei province, hospitalization rates for people between the ages of 30 and 60, so younger age cohort, was substantial versus hospitalization rates for people with flu in the United States in those same age ranges, which is very low. And so what it suggests is that even if you're not seeing the high fatality rates for people who are 30 to 40, 40 to 50, 50 to 60, they're still getting very sick. And when they're being hospitalized, the people in China who were hospitalized weren't hospitalized just to receive O2 by nasal cannula. They were hospitalized and receiving advanced care. So they were very sick from the virus. And so you're seeing a percentage of patients that while they're not succumbing to the virus, they're consuming enormous healthcare resources and getting very sick to the point where it could very well have sequelae long-term in terms of long-term morbidity that they accrue as a result of the acute episode. So I'll close there and hopefully leave time for questions. But this is something that I think we're gonna have a difficult couple of months ahead of us right now. Hopefully this will start to peak sometime in April and we'll be coming down the epidemic curve into May, and hopefully July and August provide somewhat of a backstop against continued transmission, the hot, sticky months. But it's something that we could be dealing with again in the fall in the form of outbreaks that would occur. Hopefully by then we'll have point-of-care diagnostics, so we'll be able to isolate and screen people better, and we'll have some therapeutics available. But I don't think that this is something that's going to come and go. I think it's something that we're going to be grappling with for a period of time now. Thanks a lot. Thanks for having me on the call today.
Thank you, Dr. Gottlieb. That was a fantastic summary for us. Really brought us up to date and gave us quite a bit to think about. You touched very briefly at the end on development of therapeutics. Could you talk a little bit more about the current work that's being done toward both prophylactic vaccines and toward therapeutics, both as far as antivirals, but also supportive therapies for the people who are really sick with the virus? What can we look at as far as what's in the pipeline for that and potential timelines to when those might be available?
So I think of this as a three-pronged strategy. The first prong of the strategy when it comes to therapeutics and vaccines is to look at antivirals that are already on the shelf and try to repurpose them for this task. That's a drug like remdesivir by Gilead, which is in 2 clinical trials in China. One, a 300-patient clinical trial looking at mild and moderate patients. Another one is a 450-patient trial looking at patients with more severe disease. That was a drug that was developed for Ebola, tested in MERS and SARS, is now being repurposed for this coronavirus. It's in some ways not an optimal drug. It has to be delivered intravenously. It's hard to manufacture. There's volatile intermediaries in the manufacturing of the drug. It's a longer course of the drug. I think it's given 3 times a day. But certainly if you have patients who become hospitalized and get into trouble, if the drug works, it could be a very important tool as a sort of a backstop against really bad outcomes. And there's other antiviral drugs that are being screened right now that were on the shelf for some other purpose, some of which were developed against MERS and SARS that are being screened to see if they have activity against coronavirus. Still early, but if remdesivir does work, there is a potential that the drug could be available in the fall. The second leg of the strategy is antibody-based prophylaxis. This is like the antibody that was developed for the treatment of Ebola by Regeneron, where you basically have a monoclonal antibody drug that targets some feature of the virus itself that you can give as a monthly injection as a prophylaxis. And in this case, the target would be the spike protein in the coronavirus. So who's this for? This would be used for people like frontline healthcare workers who are going to be exposed to coronavirus. You might use it in people in nursing homes or people who are uniquely vulnerable to coronavirus, people who are immunocompromised, maybe going through chemotherapy. If we had a drug like that and there's a potential that we could have that drug available as early as August of this year. If we had a drug like that, it would again prevent a natural backstop against continued transmission, since a lot of the transmission is in the healthcare setting and could be by healthcare workers. It would also reduce the overall morbidity and mortality, because you'd be basically giving a prophylaxis to the people who are most likely to succumb to a bad outcome. The third leg of the strategy is a vaccine strategy. There's multiple efforts underway for different vaccines. I think we have to be realistic and believe that a vaccine is probably a year away. I don't think that we're going to have a vaccine sooner than that. 2 years away, excuse me. I think a year is ambitious. Maybe within a year and a half we might get lucky. But I think we really need to think of a vaccine being available for mass inoculation at least 2 years away. Could be available earlier than that for vaccination of frontline healthcare workers, but I think that in this setting, unlike with H1N1 in 2009, where we inoculated our frontline healthcare workers first, I think in this setting you'd probably be reluctant to inoculate your frontline healthcare workers, because there is some theoretical concern that a vaccine could effectively potentiate your susceptibility to the virus, and so you wouldn't want to mass inoculate your frontline healthcare workers only to find out later that you made them more susceptible to getting coronavirus.
Great. Thank you, Dr. Gottlieb. One more topic that we've had a number of different questions come in about and kind of asked in a variety of different ways are about temperature and the virus. First, whether temperature is effective at killing the virus. Some questions about whether a sauna could be useful in treatment, which sounds relaxing but maybe not all that effective. And questions about whether we'll see the curves change with the warm weather, but also whether this may be why we haven't seen as many cases as expected in some countries like India, where you might expect a community spread to be a big source of infection. Could you talk a little bit about temperature and climate and how that might affect it?
Well, so typically coronaviruses don't circulate in the summer. This one is probably going to be different because we have no cross immunity. So people are probably going to remain susceptible to it even in the warm weather. But we should see decreased transfer in the really deep months of the summer, so think July and August. And that's for a couple of reasons. Number one, there is a general belief that things that transfer through droplet transmission don't transfer well in hot, humid air, and there's some evidence for that, particularly the flu, where those studies have been done. So, the hot, humid months, July and August, should prevent somewhat of a backstop. The other is that epidemiology of spread changes in the summer. People are in close quarters. They don't go to the mall anymore. They go to the beach. They're out and about. And those small changes in behavior where people aren't in close proximity can have a very big impact on the epidemiology of spread. And so you get less transfer of certain things that spread through respiratory droplets in summertime. You get more transfer of things that spread through fecal-oral routes or the pool, because people are obviously doing different things. They're going to picnics, stuff like that. So the epidemiology of spread of respiratory diseases changes in the summertime. So I think that the summer should help. I don't think it's going to break off chains of transmission just because this is novel. If you remember the 2009 H1N1 season, that was first diagnosed April 15th, 2009. There was a case in California. Second case that was diagnosed in the country was about 2 weeks later. What we didn't know at the time was that it was already epidemic across the whole country. That flu continued to spread all the way into June, which was obviously unusual for flu. Flu season ends, latest March. That flu continued to spread all the way into June. July and August, you saw the flu abate, but there still were isolated cases. And if you remember, a lot of summer camps were canceled that summer because they had cases of H1N1, and then it came back in the fall. Now, the only difference at that time was in 2009, in September 2009, we licensed the first vaccine for H1N1. By October, we had licensed 5 vaccines and vaccinated frontline healthcare workers. And by December, we had mass inoculated the entire population with 100 million doses of vaccine for swine flu. So we're not going to get that lucky this time. We're not going to have a vaccine ready in the fall. And so it is the case that, while this probably is likely to dissipate, in the really sort of deep months of the summer, it's going to come back. Just to give you sort of a proxy, it's pretty warm in Milan right now. It's 60, 70 degrees, and they're getting pretty good transfer of this. In Wuhan, when this epidemic was raging, it was in the high 60s. So it was warmer in Wuhan during the height of this epidemic than it is in Chicago in the summertime. So I think that the weather is going to help, but it's certainly not going to be a panacea.
Thank you, Dr. Gottlieb. Jeff, do we have one more question for Dr. Biddinger before we wrap up?
Sure. Dr. Biddinger, there were some questions around disinfectant wipes not covering the coronavirus. And can you give any simple guidelines of what products, bleach, isopropyl alcohol, or whatever is best to use for disinfecting COVID-19?
Sure. So as a little bit with transmission and how it relates to seasons and temperature and time, as Dr. Gottlieb was saying, we actually know that, or we're learning that COVID-19 has a variety of survival time on a lot of different surfaces, depending on the surface, the temperature, the humidity, et cetera. But the CDC has put together a nice website about disinfection for COVID-19 and has a link directly to the EPA-registered antiviral disinfectants that are appropriate for COVID. We certainly think that, unfortunately, the virus probably can live on many surfaces for up to a week, maybe longer, definitely longer in certain circumstances. So good environmental decontamination is absolutely essential, but the CDC's got quite a good resource there if you just head to that link.
Great, thank you.
Thank you, Dr. Biddinger. I think we're almost at the end of our time. That's about all the time that we have, questions we have time for today. I'm sorry we didn't get to all of them. We had more than 100 questions submitted to us during the call. Dr. Gottlieb and Dr. Biddinger, thank you so much for your time and for sharing your expertise with us. And thank you to the audience for joining us. If you'd like to listen to this broadcast again, you can use the same link that you initially used to register and to access the broadcast. The archived version of the broadcast will be up in about 24 hours. Thank you very much to everyone for joining us, and have a good day.